All right, I have 3:01 on my clock, and I grew up in a very, if you're not on time, you're late. So we're gonna get started. So welcome everybody to episode number 5 of 6 of PinPoint Plans. I'm excited for this conversation because the reality of this is this should get your wheels turning in regards to all of the various levers that we have to pull here on the PinPoint Plan. So just some housekeeping. Again, if you've not used Zoom yet, I am shocked, but in case you need a little refresher, the Q&A feature down at the bottom or the top, depending on where your little band is, please at any time pop in a question, a comment. I might throw out a poll here and there to ask some questions, but please engage with us. We do not want to make this a monologue. We absolutely want this to be an engaging conversation. This webinar is being recorded. If you don't like it, kindly hit goodbye and you don't have to worry about that. The replay will be out tomorrow. If you missed any part of it, you want to download the slides, or somebody in your office did not be able to make it, please know that you're going to get a copy of these slides in an email tomorrow. And we'll talk about this at the end as well. But you do have an opportunity to co-market these things. Guys, if you're not taking advantage of inviting your prospects and clients to the employer version of these, you're missing out. We've got people that have gotten appointments and close to closing business because they've invited people to these. So make sure you're taking advantage of that. So I want to frame the conversation in a category that we call alternative reimbursements. So really what we're talking about is how much does the plan, your client or your prospective client's self-insured health plan, how much do they reimburse for services that are being provided? If you think about how it happens today, you utilize a Blue Cross, a Aetna, a Buca system, right? Buca, let's just play with Cigna as an example. Cigna has relationships with hospitals. They've got a contract. That contract stipulates how much the plan reimburses for services that are being provided. In this conversation, we are talking about going direct, not using the insurance company, but rather having a direct relationship between the plan and the people performing the services. So let's just take you and give you a couple of examples of certain people that are doing it. Boeing's been doing this for years, where they've got a direct contract up in the Seattle, Washington area with healthcare providers in that marketplace and have been having huge success. GM, they're going into their 3rd year with a relationship there in Detroit with the Henry Ford Health System. Again, huge relationships. And the one that is probably the coolest is Walmart. Now, Walmart is doing things where they've set up centers of excellence across the country. And so you'll see this is actually the website for Walmart to promote this to their own employees. And what they're basically saying is, hey, if you utilize this, you're going to get 100% coverage. It's going to be free. So this is for orthopedic, typically procedures. And what you should know from that is Walmart has done an evaluation of quality providers across the country that should be in their COE, their Center of Excellence. But the reality of it is none of them for orthopedic are in Bentonville, Arkansas. They're literally going to put you in the Walmart jet to fly you somewhere because they figured out that it is cheaper to get you to the highest quality. And that all stems from the conversation. We always talk about how much we pay for healthcare. What's our premium? What am I paying? What's my copay? But we rarely stop and turn the conversation around and say, what is the actual cost of healthcare? And that conversation has historically been between company on the left, which should be a health insurance company. And I didn't want to put anybody's name on there because I didn't want to get in trouble. And on the right, a hospital system. So if you can think about those two scenarios, I know that most of your experience has been with the BUCAs, but the reality of it is, do they have a vested interest to lower your cost? One, do you even know how much your plan is paying? Two, the reality of it is, and we've shown this slide before, what your clients call premium, the health insurance companies call revenue. I want you all as business owners and people in this business to raise your hand if you wake up in the morning wanting to lower your revenue. Oh, nobody does. So the reality of this conversation is really conversation around going direct. So for those of you that don't know, again, I'm Lester Morales. I am part of the PinPoint team and super pumped to be hosting this webinar with two of our featured speakers, which spend entirely their all day long talking about this subject of going direct. So for an introduction standpoint, Carrie, Rob, do me a favor. We'll go in order of the screen here. Carrie, you go first. Please introduce yourself, your company name, and what's the number one thing you want everybody to take from this webinar today?
Sure. Well, again, Lester, thanks for the introduction. My name is Carrie Smith. I'm the Chief Network Officer for Employers Health Network. We're a company based out of Charleston, South Carolina, and we build high-performance custom narrow provider networks for self-funded employers around the country. I think the number one thing I'd want you to take away from this is that while you may be getting some good service on occasion for your self-funded clients with administrative service only contracts with the carriers, we'd like you to know that there is a better answer out there, and we'd like a chance to talk with you a little bit about it today and in the future if you're interested.
Perfect. And Rob, talk to us about Sano and Everyone Health.
Sure. Thanks, Lester. Yeah, like the slide says, my name is Rob Higdon. I'm the president of the firm Everyone Health and Sano Surgery. Just real quickly, Sano Surgery is a direct, bundled, all-inclusive price entity. It's gone out all over the country and gotten bundled direct prices for everything from a basic lipid panel to more complex MSK procedures, knees, total joints, things like that. Everyone Health is the entity that self-insured employers use to access those contracts. And the one thing I would like everybody to know at the end of this call is, unlike the healthcare system acts today, you can know beforehand what the cost, what the price is for a procedure.
Perfect. So guys, we've had this slide before, everyone, so I wanted to keep the theme. So it goes along with what these guys were talking about. If you hear nothing else, I'm going to drill in your head that these strategies, from everything we've talked about before all the way through today, are a win-win-win. They're good for your client, they're good for their employees, and what you'll hear today from these two gentlemen are the actual facilities, the hospital systems really do enjoy these conversations because of bullet point number 2, typically a hospital. And if you could think about this, what has been the mechanism of keeping costs down year over year? It's just been cost shifting, right? We've been increasing deductible after deductible after deductible. Well, the average deductible now, last survey I saw said $3,200, $3,300, but the average person doesn't have $400 in their bank. Those ratios don't make sense. So when one of the employees that's covered by one of your clients goes into the hospital and has a $3,000, $4,000, $5,000, $6,000 out-of-pocket expenditure, they can't pay all of that money at one time. So that hospital becomes a collections agency, and it costs them 30 to 50 cents on the dollar trying to collect it. So these guys are going to show you, when we go to these conversations, hey, why don't we eliminate what your cost is, and therefore you don't have to chase it? Well, that's good for the employer because they're saving money. It's great for the employee, and the hospital wins because they don't have to chase it. And the one also thing I wanted to say, which is the cherry on top, If you are country club buddies, you play tennis with the CFO of a hospital, you are already currently working with a hospital, the reality of it is we can turn that relationship into a program that can be highly beneficial for everybody involved. So we are going to start this fireside chat. So what I want you to imagine is that we've got a bourbon in hand or your beverage of choice. It could be a water if you don't drink. And we are having a conversation, and it's stemming from this slide that we showed a couple of episodes ago, which was what are the levers that we need to do to change the status quo? We've already talked about reference-based pricing as a way of changing the reimbursement. Now we're going to talk about direct purchasing and bundled services. So we're going to start with direct purchasing. So guys, my question, and I'm going to take this off presentation mode and let's have a conversation. Direct purchasing, just simple. What is it? And Carrie, let's start with you. What is your definition of direct purchasing, direct contracting, whatever we want to call it?
Sure. So direct purchasing, or what also is often called direct to employer, is where an employer through a broker or an advisor accesses a network of providers without going through essentially a carrier. So Lester's already talked about the BUCAs. A lot of times employers think the only alternative is to go to maybe you've got fully insured business with Blue Cross, and it seems logical to put your self-funded business with Blue Cross. And sometimes that may make sense, but in many instances, there are a lot of ways that are companies that innovate like mine, but others as well, that have innovated by putting all of the componentry together, similar to what you would get from an ASO, but with a much lower unit cost and with a true partnership with a hospital system, for example. Lester mentioned a little bit before, and we'll get a chance to talk a little bit about it more as well, sort of the country club example. There are hospital systems that work with us and others around the country that are looking for a strategy to get much closer to the employer. They realize that self-funded employers are usually folks that are located locally that are in their community. They would like to look at ways to reduce their reliance on the carrier-based strategies and the amount of volume they get from the carriers. And in essence, and Lester, kind of to bring it back around, and for the group out there as well, it's a way to look at getting network access that your employees and your employers need and want, that's going to give them high quality health care that's measurable, but that's going to reduce costs, not just through unit costs initially, but also through eventually getting to value-based purchasing and ways where we can manage the population to reduce utilization as well. Because what's the least expensive MRI you can get? It's that second MRI that somebody might order in 6 months that you don't actually need. So there's a lot of components behind it, but at a high level, that's really what we consider to be direct contracting or direct to employer.
Perfect, perfect. And Rob, so we talked about the direct side. Now let's do the definition of the bundle, right? We've heard that word bundle. What is it? What does it involve? Just walk us through the bundle 101.
Sure, happy to, Lester. So in a what I'll call the traditional environment, you don't have a single bill from the hospital or the provider generally. You get multiple. Anybody who's had any kind of procedure that was more than just an office visit has probably gotten multiple EOBs. Typically, there's between 5 and 7 EOBs that a patient will get following services. So think of each one of those component pieces as parts of a bundle. So what we have done at Sono and Everyone Health is gone to ambulatory surgery centers, surgical hospitals, providers all over the country, those who are board certified and fellowship trained. I'll just make that quick distinction because we generally get questions about quality when we start talking about the dramatic reduction in price from what someone's used to paying at a hospital to what they pay at one of our surgery centers. We will get a total bundled price, all inclusive. So that includes the facility fee, anesthesia, if any, the implant in cases where there's an implant, and the physician fee, and anything else that might be included. And in some instances, our contracts include PT following the procedure. So if you think about, I mean, the bundle in its simplest term is kind of self-explanatory. It's one of the few things in healthcare that actually sounds like what it is, right? It is the requisite pieces of all of the individual bills that providers send to patients.
So, Rob, you mentioned a conversation that because I have lots of clients with you guys, obviously, I have heard before, the quality aspect. There is such a misconception that the higher the cost, and this is for both of you, but Rob, we'll start with you. The higher the cost has to be the better quality, and there's no way that hospital is not as good as that surgery center over there. How is that possible? Can you hit on that?
Yeah, sure. So a couple of things just to kind of lay the foundation of the comments I'll make. Number one, bear in mind that hospitals are the places that people go to be really, really sick, right? So if you need a knee replacement, for example, right? Thousands of these done every calendar day in this country alone. Do you want to go to the place where they're housing COVID patients, where they're treating all kinds of illnesses and sicknesses and diseases, where infection rates can be high depending on the facility? Or do you want to go to a place that specializes in that and they do hundreds on their own every day? Well, our thinking is you'd want to go to the place that specializes in that. And as I said a second ago, we ensure that our providers are board certified and fellowship trained. So what does that mean, right? Because we get sucked into these questions about quality a lot. We actually gave a presentation to a labor group last year that said, no, are you guys out just sending us to the veterinary clinic? I mean, just, really, that's what these people thought was like, how in the world can you bill us $19,500 for a knee when I know that we paid $80,000 last year through the health plan? Like they just, and rationally, you think that, right? I'm paying more, it's worth more, it's higher quality, it's better outcomes. Well, it's not. So our providers are board certified. So they are approved by a board of their peers that are also specialists in that area. And fellowship training is generally another between 2 and 4 years, depending on the specialty, of additional training beyond medical school. So we're also kind of trying to address the people that say, oh, you just got these kids right out of medical school, they haven't done any of these. No. Our people have done a fellowship, so they have done additional training above and beyond what is required, so that we know their quality is good, we know that they're practiced in this, and we know that they have done many, many procedures before we even start speaking with them about being one of our providers.
Perfect. Carrie, same thing. Talk about when you have a conversation with somebody about, wait a second, how are you bringing back a better deal than Blue Cross bought me? It must be a second tier system or whatever that might be. Talk about the quality aspect here.
Sure. Well, first of all, I agree with everything that Rob said about moving surgeries that don't need to have that don't have to happen in an acute care hospital offsite into a safer environment. Completely support that. I think if you look at quality, what is quality, first of all? A lot of times to an employer and to an employee or a member, quality isn't necessarily knowing the difference between half a day extra length of stay if you go in to have a baby, for example, at hospital A versus hospital B. A lot of times it has to do with things like even how you're treated at that hospital and what the patient experience is. We have tools that we can use when we're building a network. So let's say a hospital system in a particular geography is one of 2 competing hospital systems, and they approach us about building a network around them so they can get closer to the employer community. We're certainly happy to do that, and that forms the basis of our business model. When we do that, you mentioned, Lester, about the difference in cost. Absolutely true that there's no relationship between how something is priced and perhaps even how it's paid for and the quality of that service. In fact, some of the most expensive hospitals in town are some of the smallest hospitals that might be a for-profit hospital system, or because of the way they contract with the insurance company, they have to cost shift a lot of what they have onto the self-funded community because they're not being treated particularly well by, let's say, the BUCAs on their fully insured business. This is a very common phenomenon that we see. So when we're approached by a hospital system, we spend a lot of time talking with them about their commitment to the employer community. If they simply want a fee-for-service contract, it's not going to offer a good unit cost discount, and they just want to be a provider and just want to treat patients, that's usually not what we like. What we look for, and there's examples which we'll talk about in a bit here when we do our case study, there are examples of hospital systems that already start off being some of the lesser expensive ones in any community where you live, but are also willing to do even deeper discounts because, quite frankly, that first of all, they know they're going to get more volume, but the smart hospital systems are really looking at the long play. And that is, how can we get closer to the provider, how can we get closer to the employer community? How can we do a better job of taking care of employees? And naturally, even those folks are going to talk to friends that work for other companies that are fully insured and going to tell them what a great experience they had at that hospital. They realize there's a halo effect by actually providing more steerage. Certainly financially it's helpful, but what they really want to do is get closer to the employer community so they can be a true partner with you. And that's part of what companies like ours bring together.
So we talked about the cost, we talked about the quality, but let's round it out so people understand the true win-win-win, right? So direct purchasing, bundle pricing, why is it valuable? And if you could hit on the three constituents, why is it good for the employer? Why is it good for the employee? And why is it good for the provider themselves? Rob, why don't you start off on that one?
Sure. So Lester, there's a one slide in my presentation. It's towards the end. It's got prices. It's got a specific CPT code. If you want to share that with the group, I'll talk about that as a really good example of kind of the stuff that we do, daily. So just to kind of level set, and everybody can kind of go back and read kind of the lead-in slides to this because it lays a little foundational understanding. But in general, when we think about kind of traditional, what I'll call health plan styled plans, the employer is paying about 80% of the cost. The member's paying about 20. That's generally the cost share on average, right? So in this example, this was a total knee replacement. It's kind of the usual suspect that I like to use because it's common enough, but everybody doesn't have one. But this is one of the places where Everyone Health makes a really big impact with bundles. So as you can see, this was an analysis we did for a single group, 2,200 members. This is one CPT code. And I believe, Lester, you've talked before about things like CPT codes. So this is just kind of a way to identify what this procedure is. This group had 15 procedures. The average hospital price was $65,000. The range was $55,000 to $136,000. So this is another place where I look at healthcare and I see the misalignment of incentives and the total disconnection between what something costs and the value it brings. So looking at this scale and kind of referencing what we talked about, and Carrie did a fantastic job of kind of putting a bow on it. You can't tell me that the quality and outcomes are better at the $136,000 facility than they are at the $55,000 facility. They're certainly not better in quality by 2x plus. So how this affects all of those entities, number one is the provider likes this because our provider contracts dictate that we pay them rapidly. Our average right now today is we're paying our providers in between 9 and 11 days. Our contracts stipulate that they get paid within 30 days. So they love that. They don't have to chase down a BUCA and send a bill, have the discount come back that's applied and kind of negotiate back and forth and get paid at some point in the future. They love talking to us. They love contracting with us. And quite frankly, they're getting paid just about the same as what they would in the hospital environment. It's just the hospital's tacking on a facility fee that's going to be 10 or 20 or 30x of what it should be, right? So they love it. Let's talk about the employer for a second. And like I said before, a typical employer-sponsored health plan is paying 80% of a procedure, well, doing the math real quick, 80% of 65,000 is a whole heck of a lot more than 22,000. And the way we advise our customers to set this up is all of our Everyone Health procedures are covered at $0, right? They are 100% covered because the employer now gets to take advantage of paying a fraction of what they did before. They can still pay 100% of the 22,000 and come out way ahead. And then the benefit is the member has a zero cost share, and that incentivizes them to access the Everyone Health providers.
And you mentioned in that example, so just to make sure that everybody understands, the price range on your plan today for a total knee is between 55 and 136,000. And they're saying, and correct me if I'm wrong, Rob, these are the facility charges or the entire cost altogether for the episode of care?
This range represents as best we could piece together, like
the total episode.
The entire episode of care. So they were charging between 55 and 136. And what we were saving them on this one CPT, this one item, if you will, if you think of medical services and procedures in terms of units, we were going to save them $645,000 on one item. So that's really powerful. When we showed this slide, people just, they get it, right? They just understand and see what we're doing.
The other thing I want to make sure that people understand is where is this surgery happening? So like an orthopedic surgery center, I know people hear that in their mind, but talk to us about that type of facility. That is somebody who only does orthopedics. So when we talk about quality, they're doing this surgery over and over and over. They're an expert in it. Is that a fair assumption?
That's a fair assumption. And in fact, Lester, you could probably take it one step further. And I would wager that in many, many cases, certainly a majority of cases, the provider who's doing the procedure in the hospital is in many cases one of our providers that they're simply doing at their ASC or their surgical hospital. We've just taken them out of the hospital environment. Same person, same person with the same amount of experience. They're just willing to do it for a better price because you don't tack on all of the hospital crap that goes along with the other model.
Perfect. So Carrie, same thing. So maybe we're not talking about an ambulatory surgery center in this example. We're talking about a full hospital system. What's the benefit here of doing that direct contract? And the mind takes me automatically to, well, wait a second. The volume that Blue Cross is pushing to that hospital is more than the volume you're pushing. Why would they do a better deal with you? Right. Talk to us about, again, the three constituents, the employer, the employee, and the facility themselves.
Sure. So from the employer standpoint, as we talked a little bit about before, there are a lot of reasons why getting closer to the employer community, getting more steerage, more volume, the opportunity to work towards doing value-based contracting. There's that and many other reasons why a hospital system would be willing to do this on their own. But in terms of the three constituents, from the employer standpoint, it's really twofold. Well, threefold, really. The first is if we can knock, in our case, when we get to the case study, if we can knock 22 to 24% off your unit cost, in addition to using something like a strategy like what Rob's talking about with doing bundled pricing, if we can knock even more with that off, that's a substantial number, whether you've got 250 employees or you got a 2,500, that's a huge saving. So from an employer standpoint, it's savings in that respect. Also can do so working our way to value-based contracting, which ultimately will reduce utilization. That makes for happier employees, which you retain, and also can address things like chronically ill patients through disease management and things that we can help execute or that companies like ours can. It's not just about us. So it can make the employer happy because it's going to reduce cost, produce something which is going to be much more sustainable in the long term than switching back and forth or switching onto a new carrier-based contract every year or so, which we see a lot of employers do. From the employee standpoint, better care from a hospital system that's much closer to your employer and does a much higher proportion of care for you and the folks that you work with. These hospital systems really get to understand you and the need of the employer and the need of the employees, and really develop a relationship almost like what you think of that you might have with your primary care physician. Imagine you could have that relationship with facilities, surgery centers, certainly hospitals, and anybody else in the community that's going to serve you. Additionally, the way we put our contracts together, this also crosses over a little bit almost onto RBP, Lester, that you mentioned. The way that we put our contracts together with our hospitals, we really break the cost down into something that's very granular in a way that would allow the employee to understand before they go, if they've got a 20% coinsurance, to be able to feed an analytics package where the employee would understand what it's going to cost them, so there's fewer surprises. Because one thing that employees and employers don't like with healthcare is they don't like surprises. And probably lastly, from the provider standpoint and the employee standpoint, the same benefit. If you've got reduced costs, we can work with folks like Lester to help you have a plan design that's going to reduce patient financial liability. Why? If the hospital knows what they're going to get paid, they know they're getting higher volume, they have a direct contract with the employer in their community. A lot of times that provider will accept a plan design that's going to give you what you want in terms of incentives so folks don't overuse care, but also something which is going to reduce the collections that employee has. Example, we did a network contract, this was a number of years ago, we did a network contract where we had 2 hospital systems in network. The higher quality, turns out the higher quality system was also the one that was less expensive. If you went and you had a C-section or a standard delivery, there was no out-of-pocket cost for that employee to go to that provider. No coinsurance, no copay. And in fact, they actually gave them a $250 rebate back if they entered sort of their healthy pregnancy program. So employees loved it. In fact, the other hospital system really complained because they weren't getting those folks anymore. But why would they when you're going to go to the higher quality facility where most of the obstetricians went and you had no out-of-pocket expense? So everybody was happy. No collections cost from the standpoint of or very few collections costs. And I would actually disagree a little bit with Lester. One of the things he said was the collections cost. We actually find for a lot of hospital systems that it costs $1.60 to collect $1 once it gets over 2 months old in their system. So it saves them money, better cash flow, faster cash flow, lower costs for all 3 constituents involved.
So guys, again, what I want to make sure everybody understands is you're not having to set these up on the front end. So you're hearing this, we're teaching you how the sausage is made. But the reality of it is you just have to know you serve really good sausage, because these strategies are built inside of PinPoint already. So we've got the mechanism to know if you have a relationship with a hospital. We partner with companies like EHN to then exploit that relationship and turn it into an overarching product. And then when the advocate is notified, they already have access to the entire Sano network to understand, that person wanted to go to XYZ hospital. We've got an opportunity over here at this surgery center, at this imaging center, at whatever. And now let's have that conversation with the member to engage them. So you don't have to worry about any of this build. This is already built inside of the PinPoint. So better benefits for a lesser cost can actually be delivered. So the most tangible way to talk about this, guys, is a tangible way of talking about it. So give me a case study, whether it's a specific group, whether it's another CPT code example, Rob, whatever it might be. Give us an example that the advisors on the phone can go out and start talking about the possibilities of putting together. So Rob, we'll keep starting with you.
Okay. So we actually had a conversation with a new customer a week or 2 ago, and some in the last 2 weeks. We were talking with their advisor, who had was relatively new to bundles and kind of what we're doing, but heard enough to know this is good. I need to do this, and I need to have my client do this. And so we had kind of built, done some custom things for them. and got on the phone with him and gave him our prices, right? That's the other part of this that I think is fantastic is you can know before you go get services what they cost, right? Because what happens right now in healthcare would be like you going to the grocery store, getting your milk, your lunch meat, your lettuce, and checking out, and them saying, oh, hey, give us $5 today and we'll bill you in 30 or 60 days for whatever this costs, because I can't tell you what it costs, right? That's really how it operates today. So the predictability of cost is one of the other attributes that I think is fantastic. So we provided him with, hey, here's our prices for all these things. And so he's sitting there on the phone and he goes, you know, what does an ACL reconstruction cost? And we were like, well, hold on, it's right here. It's $4,000. That's what it costs. And he kind of made this audible noise, almost like a guffaw. And so one of my business partners who was on the phone with me said, he goes, well, you know, Chris, that's actually a really good price. And he goes, I know it's a really good price because I just paid for one of these last year for one of my kids. $13,000 was what he was billed. And that didn't include the facility or the provider. So like this, and we got examples like this all day long. Our goal here, and I know that Carrie is like-minded. Our goal is to change healthcare in a way that makes it affordable and predictable, because who says that you can't know what something costs and budget for it, plan for it before you go get services?
Perfect. I love it. And I want to come back to that ACL because I have my own live example that happened on my own left knee that I like to share. So Carrie, same question. Give us a case study. And I know that we talked about a specific market, that there's actually AccuSure partners that might be on the phone in that market. Talk to us about that market specifically.
Right. Sure. In fact, that market has one of AccuSure's constituent companies, Lassiter actually has a group on this network. So it happens to be in my home market, which is Orlando. So in Orlando, two major hospital systems in Orlando Health and Adventist Health, used to be Florida Hospital. We were approached by Orlando Health about 4 years ago about building a high-performance network around their hospital, and they have a lot of employed physicians, really have a very complete network. They also have a clinically integrated network that wraps around that. We started with them in 2018, and in our case, we were able to negotiate contracts with them that were on average around 22% better than the best contract that you could get through a carrier. Here in Florida, it's Blue Cross of Florida. So it's 22% better than Florida Blue. But there's a lot more to it than that. One of the things, for example, that's really great when you get a hospital partner, and this one was not brought to us by an advisor. This was brought to us because we knew the folks there. If it had been brought to us by an advisor, it would have even been better, because Orlando Health will actually has folks in their leadership. In fact, we're meeting with them tomorrow, that will go out with us, with the advisor, to meet with an employer. So imagine going to an employer and bringing a representative from a hospital system, a high quality hospital system, proven such, that can say to your employer, or whether it's a group that you have now, or whether it's someone that's a prospect, and say, we guarantee you that this network's going to have the least expensive prices, and we will work to get experience with your members to be able to get to value-based pricing. And we're willing to work with you to have your plan design modified to reduce patient financial liability without any negative impact on the way that the employer actually winds up paying for their portion of the bill. And finally, we've got folks that will go out and meet with you and make you part of the governance of what we do with this network. So if you're an employer and you want an opportunity to meet with us quarterly to tell us how we're doing, good, bad, ways to improve, we're willing to meet with you on that. One of the other things for the folks that are out there that have a lot of experience with self-funding that we do is both Orlando Health and we will go talk with your stop-loss carrier. So when you're getting a rating for stop-loss, they'll actually call and interview us and talk to us about the contract. What happens is, if you've worked with stop-loss, you know that an actuaries hate uncertainty, and uncertainty, what they do is they raise their rate and they raise their quote. What we do is work with them directly in conjunction with Orlando Health and with the advisor to make sure that we eliminate any of that uncertainty so that we get a really good renewal or really good quote from stop loss. And as you guys know, stop loss after the premium, stop loss is often, or well, actually the cost of care, stop loss is often the second or the third most expensive expense to the employer. So I think we've really done a good job of working with these folks and folks like Lester to put these programs together in ways that are sustainable, that will save money with high quality and take great care of the members.
So what's interesting about that, Kerry, we, obviously AccuSure and the PinPoint plans are foundationally built with Breakpoint, which is their stop loss arm internally. What's great about that is Breakpoint already has familiarity with direct contracts because we do that already in the PinPoint. So you're exactly right that when we're able to show them, because remember, what happens today, a discount off billed charges, nobody knows what a billed charge is. It has no relativity. So first, with reference-based pricing, we're using at least Medicare. Even better with direct contracting, we know what the price is because the contract stipulates what it is. So it cannot get more transparent than that. So I'm going to open it up for questions. Anybody who has a question, please type it in. But while we're doing that, I was going to share my own live example. So most of everybody knows I was with Willis for 14 years. About 10 years ago, I tore my ACL, my MCL, and my PCL in my left knee. I was doing something really stupid and my kneecap ended up on the wrong side of my leg. My surgeon told me to go to Tampa General Hospital. So what do? You follow the instructions of the surgeon. So the bill charges were $95,000. Well, I'm not very good at math. I'm going to drop that down to $90,000. So let's just say it was $90,000 and the carrier had a 50% discount. So that now means 90 broken down to 45,000 with that 50% discount. I had my $5,000 out of pocket expense. The plan picked up their 40. Okay. So 40 and I paid 5. What I now know is that South Tampa Orthopedic, which is 1.2 miles away from Tampa General, who only does orthopedic surgeries, will do that exact bundle for $19,500. So in this example, the $5,000 out-of-pocket expense that I had plus the $19,500 is $24,500 versus the 40 that the client picked. In my scenario, it was Willis. So my employer, Willis, paid way overpaid, and I could have actually got to a facility that only does orthopedics. So to that point that Rob made earlier, there's nobody sitting in the waiting room that has COVID at an orthopedic surgery center. So the reality of this, guys, if you can turn, and this is one of the things that I want everybody to get off this phone thinking, if you could turn a relationship that you might have with a local facility, a local hospital, a local imaging center, you could turn that relationship not only prosperous for you and a particular client, but maybe talking and turning this into an entire program, which is huge. So there's a couple of questions that came in. And I think people maybe heard something and it's like, wait a second, that doesn't make sense. That's too good to be true. I got to confirm this. Rob, one was for you. So the question was, I could really keep my same surgeon who wants to do the surgery at hospital ABC. You've got an ASC. I could really keep my same surgeon in that scenario. They thought that the surgeons were owned by the hospitals and that couldn't be the case.
Yeah. So a couple of things to clarify. So the part of the reason there are ambulatory surgery centers and surgical hospitals is because the providers, they went out and said, hey, let's build our own surgery center, right? I don't want to be controlled by the hospital that is dominant in the area in which I live, right? So those ASCs and surgical hospitals exist in part because of the surgeons. Now, we have a contract with that facility. So the way our contracts work is they operate with that facility. The way that carriers' contracts work is they are operated by provider and then also by facility. So in many cases, the same provider that would be performing the surgery for the patient at the hospital will be contracted, well, essentially through the facility that we have a contract with. They'd be doing that same procedure at the facility. Now, that's not to say every time in every instance, but the vast majority of the time, it's going to be the same provider.
That's amazing. So I could get to a facility that the plan will save a significant amount of money, keep my surgeon, and potentially, and most often, eliminate my total cost. And so that's just amazing. And then, Carrie, the question that it got put into the chat was free baby, question mark, question mark, question mark. So you were giving your example that said, well, wait a second, you've got a deal built with a hospital. The deal is so good. It is the hospital that is best, that all the moms want to have a baby, but the deal is so good that the employer can waive the cost. I have a legitimate free baby through this arrangement. Did they hear that correctly?
Free to, in essence, free to the employee. That's correct in that case. Yes, not free to the employer, but the employer is already going to be paying something that's deeply discounted. Actually, because obstetrics is so important, even within the realm of reference-based pricing, we carve out the price of obstetrics on inpatient services for hospitals. And hospitals are willing to do that because they understand a little piece of information. Even at full cost, hospitals usually lose money on obstetrics. Not a lot, but it's not a big moneymaker for them. Why do they have it? They have it because it's a community service, and it's usually a lot of people can think of the age you are when you usually typically have a child. That's usually your first entree into the system, and that's your first experience with the system, which is why they have that. So there's a fair amount of flexibility with regards to those rates. Now, that was an unusual situation. That was a bit on the not typical, but however, we can work with you as an advisor and with your employer to drive or your client to drive the behavior that you want. And if we've got a good enough price, if it's 20% less expensive and it's going to be good care, and you can get, particularly if you get the person enrolled in something which rewards them for being in a prenatal program to make sure that they don't become a high-risk pregnancy, because that's one of those things I'd forgotten before, that you have your own stop loss. You know, what keeps stop loss carriers up at night? Cancer, NICU, high-risk pregnancy, things like that. A lot of times employers will make decisions to really try to incentivize the employee to go to the least expensive, high-quality facility, and they will oftentimes very much reduce the patient financial liability for that.
Perfect. And a question for both of you that came in too is, hey, how do I know this is even available in my market? Like, is this a conversation that can be started in any market, or is this something that's kind of limited to certain areas? And Carrie, since you have the mic, go ahead and keep it. But is the conversation you're able to have with a direct contract with a hospital, can that happen in any market?
Yeah. So if you're in a really rural market with one hospital system, or if you're in Lee County, Florida, which has one hospital system that has the entire county and there's not much really around the margin, the answer is probably it would be more difficult to do that in that market. If you're in a market that's competitive, and to give an example, we've got high performance networks in areas that are relatively compact, like Orlando, Florida, and Austin, Texas. We also have high performance networks in Los Angeles, California, and New York, and the New York City metropolitan area, New York, New Jersey, that part of Pennsylvania. What you really have to do is, every market is a little bit different. What I'd encourage you to do is, if you're interested in exploring that, is to talk to Lester about where you think the possibility to really get some mass, enough employers and employees interested in doing something like that. If there's not a high performance network there now, but if you've got a good relationship with a hospital system and you'd like us to work with Lester to explore if they would be a good option or if they would be interested, I'm sure we would love the opportunity to explore that with you.
And Rob, on the bundled side, it would seem like geography, assuming they're not owned by a hospital, that every independent ASC or independent imaging center would be all about somebody getting more business into their walls. Is that a fair way of looking at it, or like, what's the geography look like for you guys?
Yeah, that's a fair way to characterize it, Lester. So our geography is we're in 46 states. There are just a couple that we have either no presence, Alaska being one of the usual suspects there for obvious reasons, and a couple others. But the other thing, just to I'll give as food for thought. There are other entities like us out in the marketplace that do bundled pricing, and we have taken a strategy that's frankly this: we wait to aggressively go into a market until we have some demand, because we want to have a good relationship with the providers, right? What we're trying to do is say, we want independent physicians, right? We don't want hospital system owned exclusive providers. We need to have private practice physicians everywhere, because it's good for competition. It's good for driving down prices. So, but what we don't want to do is say, hey, doctor, we're a bundled provider. We've got self-insured employers that want to save money. Will you work with us? Yeah, okay, we'll work with you. That's great. And then have them 6 months later say, how come I don't have any cases? How come I'm not getting any knees or joints or PT or whatever? So we build out the network where we have demand. And like I said, we're in 46 states, so we've got demand most places. But when we have someone that's in a given location, we will then aggressively go and find usually one or two more providers that we can add to the network, because more choices is better than fewer, and competition drives down prices.
Perfect. And for the Acusure audience out there, we have built a fairly extensive network in the Michigan market. I know that there's a lot of Acusure partners in the Michigan market. There is, and it's because of Sano's help that we've been able to do that. So if you're in the Michigan market, know that there are some options definitely there. So parting shots. So one of the things that I like doing in these is the audience, they listen to a bunch of webinars, they hear a lot of things, they see a bunch of emails, they get a bunch of things, and then life happens, right? You go back to your desk and it's open enrollment season. They're just busy. So what's the number one thing in a minute or less, guys? What's the number one thing that you tell advisors to get off of this phone and either start doing, stop doing, start thinking about something that can impact them and their clients? What's the number one thing? And Carrie, we'll start with you.
I'd say the number one thing is to take a look at your business that you have that's self-funded and think about what it would take and what you would need and what would be attractive to your employers and your clients that would save them money, give them much better visibility into their data. We didn't talk about that, but one of the nice things about working with an approach like what we're talking about is we have complete data transparency for the employer to understand where they're spending money. You don't get that through the carriers. If you think you do, unless you really, really are a large, if you get a large book of business, you might get some of it. Try going and getting claims data to be able to do any analytics from one of your carriers that's doing your ASO business. It's impossible to do. Think about a different environment that would save money, guarantee quality, give you better access to data, and actually give your employer a hand in evolving the healthcare spectrum that takes care of their employees. And if that's something that interests you or you'd like to explore, I would say never be afraid to ask the right questions. It's very easy to fall, and we understand that too. It's very easy to fall back, and it's easy. There's an old adage, used to be, nobody ever got fired for choosing IBM. We've heard brokers and consultants and advisors say to us, nobody ever got fired for choosing Blue Cross or United. Think about what it would take and how we collectively could help you with Lester. Maybe look at something different that would give you something much more sustainable and build even a better relationship with your constituents.
And again, guys, I want everybody to realize if you have a hospital relationship, they're a current PNC client, they're a current EB client, you haven't broached the conversation of expanding that relationship, it is a huge revenue opportunity for you. So let's make sure that we're chatting about that. Rob, your parting shot about bundles and about what can people do differently? What should they start thinking about?
So I'll say two things real quick, Lester. The first one is, everybody's in the mindset, and you actually made me think of this because you said, it's renewal season, people are kind of in the thick of all of that stuff and very distracted. We can implement our program on a self-insured plan anytime. It doesn't have to be done at renewal. So, which leads me to my second point, and probably the most important, which is, everybody out there has a client right now that is suffering financially. What's happened in this country with COVID and coronavirus and the shutdowns, it doesn't matter what state you're in, everybody has clients that have been impacted by this. And there are companies out there that are trying to decide, do I keep my staff? Do I have to lay them off? How do I cut? How do I save money? And our solution allows them to slash expenses in the second most expensive column on the spreadsheet. And we are ready to get to work for customers and want to serve, but we want entities and companies that are hurting, that have to make a decision between, I got to lay off people or not stay in business, right? Those are the people that we want to talk to, because I think what we can bring to them and the value that we can add through this collective relationship is so important. And I think it's the difference between staying in business, quite frankly, and not, or providing income for employees and a job and not. So we'd love to talk to you. Really appreciate the time this afternoon, Lester. Thank you.
No problem. And my parting shot, guys, is one, all about growth. It is not too late. So what's amazing in this is very rarely during benefits time are we ever talking about anything that is good news. We are typically delivering a rate increase, a deductible increase, a contribution strategy increase. And this is a conversation that you can bring that is not only going to get people a better cost, but a better overall experience. So they are going to get to a higher quality place more often than not for a cheaper cost. It is a no-brainer from a conversation standpoint. It's just a different conversation that needs to happen. And again, maximize your relationships. If you have relationships with facilities, let's have that conversation. So to end this, remember, save the date, November 10th. This same conversation is going to happen for employers. I can tell you, based on the schedules that these guys have, employers love having this conversation because everybody would want to offer the same benefits that Walmart is doing, that Amazon is doing. And this is the conversation to bring that down to the middle market and embed it already. It's already embedded in the PinPoint plan. So November 10th, the reality of it is you will be getting emails that allow you to forward the invitations to your prospects. If you're not getting those, please let us know. So these emails will be coming your way. You could just forward it to your prospects and they're gonna be able to join and put your name as the joiner code. And so we'll know that people are joining for you. The reality of this is, the great part about it, all of this can be done on an impact analysis. So if you have a prospect that you're thinking, man, they might like this conversation, we can absolutely do an impact analysis. And lastly, if you have any questions or you want to get a PinPoint quote, remember, pinpoint@breckpoint.com is the email. You can get all of the information. You can submit a quote and everything. So I appreciate everybody's time and attention. To my speakers, Rob, Carrie, thank you so much for the time and shedding some light. I hope everybody got some value out of it. We look forward to hosting your clients and your prospects on the next one. And we'll talk to you guys soon. Thanks so much.
Thank you.
Thanks.